So now please be honest. If you have a patient, are you more homeopathic in thinking or are you more clinical in your remedy choice?
I would start out first, I have to be clinical. The feet are cold to touch. And I ask the patient, do your very cold, almost icy cold feet bother you? Do you want your feet warmed up? He says, no, it doesn't bother me at all. Right? It's better, and the pain is better if I keep my feet ice cold.
Hello, dear friends, homeopaths. This is Barbara Liberowicz, Homeo Sapiens, and my guest today is Dr. Herman Dżegas. Dr. Dżegas is my favorite clinician and also experienced homeopath. We already discussed infective endocarditis treated with arsenicum, which I announced it is the case of the cases of all the times in homeopathy. And the other video was dedicated to peripheral circulation. And today we agreed to talk about chronic leg ulcers, which, as we know, is a part of medicine where you often are not successful and the condition is very difficult to treat, and patient would do anything to improve. How happened you started to have chronic ulcer patients?
It happened more than 25 years ago. I started working in the Cape Town area in end of 1994, so 1995. And I soon started to have quite chronic patients, severe eczema patients, etc. And of course, there's no shortage of diabetic patients here in Cape Town. And very soon, patients with chronic ulcers, whether arterial or venous ulcers, came to consult me because of their severe pain, and these ulcers are not healing, and they don't want to have an amputation. That will rob them of their independence. It means no more car driving, no more walking, and so forth.
Before we start, in homeopathy, we talk about similar rule and about totality of symptoms. So now please be honest. If you have a patient, are you more homeopathic in thinking or are you more clinical in your remedy choice?
I would start out first, I have to be clinical. We will not discuss too much homeopathy, but that is what Samuel Hahnemann said himself. So if a patient comes in with, I have diabetic feet and so forth, I want to clinically evaluate what is going on with this patient. So a diabetic patient can also have venous ulcers, but of course it can be arterial. So I'm first clinical.
We often have story that patient comes with severe pes diabeticum, or patient comes with severe chronic non-healing ulcer, and they all admit it started with the injury.
Yes, indeed. Very often, say I have seen a patient already. When that patient has an ulcer, I warn them, say, please watch out, do not injure your feet. Do not let grandchildren step on your feet. It will just worsen it. And of course, some patients do have, say, borderline vascular status, and that injury alone can cause ulcers to come on or can make toes go completely black, where that shock of that injury can just shut down the blood supply of that patient.
What is your approach? What do you start with during the consultation?
My approach is a patient makes an appointment, come to the door, and I observe how they walk in. So a patient with diabetes already shows signs of peripheral trouble. Those patients walk in difficult. They walk in with a wide pace, means that their legs are apart. That already is a telltale sign to me something's not okay. So just after taking off shoes, socks, and so on, you can already see telltale signs of peripheral vascular disease. Or if those patients have varicose veins, there will be signs of that. So if we look at the peripheral vascular disease, so arterial insufficiency, those patients will have red toes as they are standing there. I'm just looking at how patients come in. They've got red toes. You can see thick toenails. You can see their toes are pulled upwards, called hammer toes.
I just wanted to be, realistic. Young generation of doctors would skip this part with observing nails and color and refill, and would perform angio-CT right away. Now, imagine you already have come up with a diagnosis, and the patient probably was already treated by multiple specialists. So, what can you offer him? What is something special that you can offer to the patient?
And you know, we are last resort for patients. So that patient has already been scared by the young doctors and the surgeons and so forth. Oh, we have to amputate. That scares them and they run away. They said, no, no, no. I'm going to look for other options. And then they come, said, now, what is your problem? I don't want to have an amputation. But now, okay, now, why do you want to have amputation? Why do they want to amputate? Because of the pain. They can't deal with the pain. And sometimes this patient already has had a bypass, or they have had a stent, and so on, but they still have pain. But a stent and so forth improves your, what we say, your large arterial flow, but can do nothing about your microcirculation. So your microcirculation is still in trouble, and the gangrene will just simply go further. Now we get to the homeopathic side. So what is your type of pain? Right? And on the basis of that type of pain, I can determine which of a few treatments can I select to treat that patient straight away in my surgery within about, say, 20 minutes to alleviate the pain.
Now we have to explain a little bit what are the key points of remedy choice.
Remedy choice is based on physical signs, number one, and the subjective suffering of the patient.
We have to explain to the audience what we understand as modality in homeopathy.
Yeah. But before I get to the modalities, just the physical signs. So some patients, say one patient has very thick toenails on the first toe, their hammer toes, etc. Their feet are cold to touch. And I ask the patient, do your very cold, almost icy cold feet bother you? Do you want your feet warmed up? He says, no, it doesn't bother me at all. Right? It's better, and the pain is better if I keep my feet ice cold. So those are the modalities, those are the subjective characteristics from the patient that assist me to decide on a particular treatment. So a set of characteristics like thick toenails, hammer toes, ice cold feet, very poor capillary refill, and the feet are better cold. The pain are better keeping cold. So that is a treatment Caeli cornutum. And then we have the exact opposite extreme, where you also see a patient, also hammer toes, but the toenails are thin, right? The patient's feet are also cold, or may not be so cold, but the patient prefers the feet to be warm, and the pain are less warm. And when you look at the wounds, there's often a purple hue around the ulcer. Their toes look purple. So on the basis of that, the physical signs plus subjective experience of the patient, decide that this is the treatment, lacusis.
What would be the differential diagnosis to arsenicum? I didn't expect lacusis to be better with worm.
Yes, lacusis is always better warmth. Lacusis is a very hot-blooded individual, but cannot tolerate cold. Like a lacusis patient cannot tolerate aircon in their face. Say warm summer, put on your air conditioning in your car. I ask that patient, do you like blowing it in your face? Oh, no, right across me. I don't want that cold air in my face. That's a lacusis patient. So with peripheral vascular disease, a lacusis patient, even with venous ulcers, lacusis patients want warmth on the ulcer. That improves the pain. An arsenicum patient, there generally is supposed to be straight toes, but you can have a combination of complaints. So you can have a patient who has features of Zicali, but also features of arsenicum. So in arsenicum patients, even though there is features of Zicali, thick toenails, hematoes, and so on, feet are cold, but the patient has cracked heels, and the patient wants the foot warm. The pain is better warm. And the pain, of course, is worse around midnight. That would be more arsenicum.
What about varicose ulcers?
Varicose ulcers, depending on left-sided or right-sided. So many patients tend to have left leg varicose. Other patients have more right-sided varicose veins. Left-sided varicose veins, you often see lacusis, but there can be other treatments as well. But lacusis. Then left-sided or right-sided can be, for instance, Vipera as a treatment. They always want to lift up their leg. Pain is much better. Right-sided, it may be Crotalus horridus or Lycopodium as a treatment for right-sided varicose veins. Of course, you also have pulsatilla, but I've seldom seen really pulsatilla ulcers.
Okay, so what would be the differential diagnosis between lacusis, vipera, and Crotalus?
With lacusis, varicose veins, it would be left-sided. Patient will also have hematoes. That's almost always there with lacusis. And the pain is better, warmth. The varicose veins are very blue, etc. With Vipera, the main distinguishing factor is that that patient will walk in and immediately lift up their leg, because from the moment of leaving the car, sitting in the car was painful, because their leg is dependent, their leg is on the floor. Walking in, coming to sit, the pain will be terrible. Then that patient will immediately lift up their leg. Say, why do you lift up your leg? It eases the pain. Okay. So that is really with varicose veins. We don't want to give too many differential diagnoses, eh?
Yeah,
With
but
lifting up the leg.
what about Crotalus?
Crotalus is more right-sided pain, very often bleeding and blistering on the right leg. Lycopodium ulcers, of course, they're always better heat. Better putting a warm cloth on there. Thick toenails, particularly of the first and second toenails, as you can see there. This is a patient from very long ago. You can see 1997. So it was 28 years ago. I treated her for a gangrenous wound. Those are the homeopathic treatments for thick toenails. But Zicali is particularly the first, second, maybe the third toenail. Graphaitis and silica are the fourth. So of these treatments, Antimonium crudum and Zicali are for peripheral vascular disease. Then the other is hematoes, physical signs. You can see more in an elderly individual. You can also see thick toenails there. That is also Zicali. So this is Zicali ulcer. Very painful ulcer in a diabetic patient who had a spinal cord injury and is paralyzed below the waist. And because of lying constantly, he cut off his blood supply, and that healed.
Okay, so this is the cubitus.
Yeah, it is. But you still need Sekeli for this because he has peripheral vascular disease.
Okay.
He's
Yeah.
chronic diabetic, right? The patient is chronic diabetic. He has paralysis below the waist because of a motor vehicle accident. And because of poor circulation, lying, decubitus ulcer, he still needed Sekeli. Okay. Now, a Lacusis patient, you also see an ulcer. There's a purple hue. The patient has hematose, and the pain is better heat. And I treated with Lacusis 200C, and the pain disappeared in about 20 minutes. And over a period of about 6 weeks, this healed up, which is very fast. Some of these ulcers take months and months to heal. This is a combination of a patient who has Sekeli, peripheral arterial insufficiency, hematose, thick toenails, but also varicose veins at the same time. She in reality had arterial ulcer in a venous insufficiency leg, really punched out, very painful. So one of the first treatments was Hepaself, and those are some of the treatments are given. And also Kali self is for an injury, an ulcer coming on because of an injury. And over quite a long period of time, because of the atrophy, the poor circulation, poor blood supply in the lower leg, it takes really long for such an ulcer to heal.
What would be your practical management? So you start with frequent repetitions, as you said.
My management of these patients, from the moment this patient comes in, I evaluate. Patient has a lot of pain. I have decided on Sekeli. This patient is Sekeli. I then give the patient 200C in a 30 ml dropper bottle. And I give the patient 5 drops of it, and I time it. 5 minutes later, I want to know what has happened. As a patient, what happened to the pain? Has the pain decreased and how much? So I make use of a pain chart. So say that patient had an 8 out of 10 pain. 5 minutes later, it is down to maybe 7. Then I repeat it. I succuss that bottle, I repeat again. 5 minutes later, the pain is down to say a 5 out of 10. I give it a third time, pain is down to say a 3 out of 10. Then I tell the patient, now wait for half an hour and see. Then the patient repeat whenever necessary to keep as pain-free as possible. However, I also supply that patient with Sekeli LM3, a low, mild treatment to keep on the healing process. It gives much more stability, otherwise you get up and down. I do the same with Lacusis, I do the same with Vipera or any other treatment. You want to get rid of that pain as quickly as possible. It means you are correct your treatment selection, and then we continue to do. And I review those patients usually within about a week. You want to see. And then as the patient get better, we extend the time for review. That's in general the management.
Okay, so Dr. Jacobs, we are so-called classical homeopaths, and we should mention totality of symptoms. How do you evaluate totality of symptoms and general improvement? These patients, I guess, they have multiple problems to treat.
Yes. No, indeed. These patients have multiple comorbidities. I treat the most pressing, most recent, as Hahnemann also said, the most recent derangement, and that is this gangrenous ulcer. That has to be treated. So I find this minimum what fits this patient's leg. That patient may have been a diabetic for 30 years. You cannot switch off that patient's diabetes. Yeah, that is way back in that patient's past. Once that ulcer is healed, we can consider others. However, many of these patients have other conditions. So many of these patients are itching. And as you know, diabetes, Hodgkin's, and so on, these patients itch. They itch a lot. So we have to treat the itching as well at the same time, synergistically.
We encourage health professionals dealing with patients with chronic ulcer to try homeopathy. There is nothing to lose. You can improve suffering of the patients, and you can, if you are lucky, you can help healing this painful ulcers or wounds.
Yes. No, certainly. That is the main reason patients come is because they've been scared. I'm going to lose my independence. I'm going to lose my leg. That is what the doctors want to do. So I would encourage them, please, there are other ways of dealing to preserve the well-being, the independence of these patients. You can do quite a lot. You can heal these patients. And naturally, if there are questions, you can contact us.
This was exactly what I wanted to say. Please contact us. We are aware there will be questions, and you might have doubts in the beginning, but as far as I remember, I have the best cases in the beginning of my career as homeopathic doctor.
And many of our colleagues must remember they can become similar patients. And what would you like for yourself? Okay.
Oh my God.
Yeah. What would you like for yourself? Would you like to have amputation, or are you going to say, isn't there something else?